evaluation of the knees. We're going to start with the examination. And the way we're going to do that is we're going to have the patient supine on a table, a pelvic bench, or a portable table, supine or face up. And the first thing we want to do is see the overall presentation. So when we're looking at the lower extremities or the legs, first we want to see start up here and see how are the hips. Does one look higher than the other? If one looks higher than the other, then there may be a potential pelvic or sacral involvement with the lower extremity condition. Now, we're looking at the femur bones, and we're just looking at symmetry. Does this femur sit the same as the left and the right? Do they sit the same? When we're looking at it, we want to look for a couple of things. One is there hiking of the knee? Does the knee present up? That would indicate a tight hamstring. Do we have rotation of the femur? Do we have rotation of the entire leg? Okay, those are things I want you guys to look out for. So going back to the visualization, start at the AIIS, anterior inferior iliac spine, right here, the hip bones up front, and see if one is higher than the other. Follow the femur down. We're looking at the shape of the femur. We're looking for any rotation of the femur bone. We're looking for tight hamstrings or hiking of the knee. Okay, next we're going to go down and follow down the knee. So we have the femur, we have the patella or the kneecaps, and then we're going to the tibia evaluation. Same thing. So if we see that the femurs are lined up, do we see any rotation of the tibia bone? And the way you may see that, it may be a very distinct rotational component that's pronounced. You may see one part of the calf muscle more than the other. That would indicate also that rotation as well. Next, follow it down. So we start femur, kneecaps, tibia. Next, we're looking at the ankles and how the ankles present. And we'll go more in depth in the ankle evaluation later. Okay, so after the visualization of the knees, we're going to evaluate the motion of the knees. So when we have proper alignment of the knee joint itself, which means we have proper alignment of the femur and tibia, this is the first assessment, we're going to be checking what's called patellar tracking. Femur, tibia, fibula, patella, these are the meniscus. We have the lateral and the medial meniscus. So normal alignment in patellar tracking is as we're bending the knee, you can see it's sliding through the patellar groove, which is formed by the femur and the tibia. So optimal alignment, it's doing this. If there is misalignment of either bone, then we don't have efficient movement of those tendons or cables, and then we can actually see what's going on here with the patella. It's going to start to wear unevenly, leading to things like chondromalacia patella or early degeneration. Okay? In patellar tracking, what we're doing is we're going to be bending the hip joint and the knee joint 90 and 90 degrees. And we're going to just look at the overall presentation of the patella in relationship to the femur and the tibia. It should be sitting in the center, okay? What happens is when we have misalignment of the femur, the patella cap or the kneecap will start to go out laterally. My stabilization hand is proximal to the ankle. I'm standing on the affected side of the leg that we're examining. The hypothenar, which is this aspect here, is on the lateral aspect of the patella. Second, third, fourth, you can even do fifth digits for larger knees or larger patients. You're going to now flex the hip and the knee. You're feeling the position of the patella. And it should be in the center the whole way down. If we're getting lateral deviation of the patella and it stays lateral, and then it starts to drop down at the end, that's going to indicate something we're going to go over. That's lateral patella. Okay, so patellar tracking is the first examination or assessment of the knee. Next thing we're going to do is we're going to evaluate for any open wedging, specifically at the meniscus, at the joint line. So we're going to be applying valgus and varus stresses. When we're assessing the knee for valgus varus stress, there's a very simple way to know which bone is the affected bone of misalignment. If the joint opens up more on the outside, the lateral side, we think there's a tibia issue. These are general rules, general considerations. There's always an exception to the rule. If we apply a lateral to medial stress on the knee joint line and it opens more on the medial aspect, that would indicate a femur misalignment. Let's go and check valgus and varus stress. I'm going to bring this leg out. You're going to grip proximal to the ankle between your thighs, just above the doctor's knees, okay? So you have control of traction. You can do this fully extended. You can also do it slightly bent. We're going to contact over here to stabilize the tibia. I'm using my thenar pad here on the joint line, and I'm applying a lateral to medial stress. And we can feel it open up just a little bit there on the medial side. We're going to do the same thing now from the medial to lateral side. And what we feel here is that it actually opens up more on the lateral side. Next thing we want to do is we want to evaluate the fibula, the proximal fibula. We're going to bend the knee slightly, and we're just going to, we can do it a couple of ways. For her, we're going to do it this way. You can either sit on the patient's leg, or you can just apply a little bit of downward pressure with your leg. You're going to stabilize the tibia, and you're going to challenge the fibula. It should go anterior, back, it should rock back and forth. If the fibula is stuck posterior, it's not going to go anymore. It's going to be stuck posterior. It's not going to come anterior. We're not going to be going over anterior misalignment of the fibula. That's usually due to a fracture. That's not going to be your case. AIN femur. Preferred move of the AIN femur is going to be patient seated on the chair or a table. Move slightly forward to the edge, please. There you go. And doctor is going to stand kneeling on one leg, 90 degrees the other leg. And doctor is going to take the patient's ankle and rest it on doctor's thigh. This allows for control of the leg. This is the right knee. It's gone anterior on the internal side. This is the internal side. Anterior means it's gone forward. Anterior on the internal side, which will cause lateral deviation of the patella, which will cause a tracking problem of the knee and of the patella. The contact is going to be the medial condyle right here of the femur, but you're going to make sure you also encompass and cross a little bit of the joint, because you want to close that wedge. While closing the wedge, if there's any bulging, we need to do a reduction move of the bulge, whether it's on the medial side or the lateral side, which we'll demonstrate in a minute. Doctor is going to contact using a thenar pad on the medial condyle of the femur on the anterior surface. Doctor is going to stabilize with the tibia, the shaft of the tibia, with the outside hand. Doctor is going to contact the medial condyle of the femur using a thenar contact. The fingers are going to wrap around the back of the knee, holding more of the femur. The stabilization is the shaft of the tibia. Doctor can also rest the elbow on the ankle. Doctor can traction to open up the joint as he or she sees fit. The adjustment happens at the last 5 degrees of extension. So I'm going to go through the basic adjustment first. We have our contact hand, we have our stabilization. We're going to traction and open up the joint. We're going to start now. It's gone anterior on the internal side. Anterior on the internal side. So we want to take out any rotational component prior to giving the thrust. Once again, we're going to flex the knee, get our contact point. We're going to come down into extension, and take out any rotation, the last 5 degrees of extension, the force is going to come through the thenar. It's lateral to medial, slightly S to I, and a slight torque down A to P. There. We're going to be going over the adjustment of the AEX femur, which means it's gone anterior on the external side. We're going to stand on the side, the doctor will stand on the side of the affected leg. Doctor will kneel on one knee and will have the other leg bent 90 degrees. Doctor will place the patient's ankle on doctor's thigh. So we'll demonstrate on the knee model. This is the femur, patella, tibia, fibula. So it's gone anterior on the external side, which will cause the medial deviation of the patella. So you'll have medial wedging of the medial meniscus. That will be seen on X-ray. It'll also be demonstrated on the examination. And we'll have medial deviation of the patella. The correction of that will be contacting the lateral condyle of the femur, and similar to the AIN femur, however, we're on the lateral condyle, not the medial condyle. So we're going to place the patient's ankle on the doctor's thigh. Doctor is going to take his inside hand and stabilize the tibia at the shaft of the tibia. Doctor is going to place his thenar pad on the lateral condyle of the femur, encompassing the lateral joint. Doctor is going to flex the knee. Doctor is then going to start to extend with a little bit of traction at the ankle. And it's the last 5 degrees of extension. The adjustment is going to be, the force is lateral to medial, S to I, and a slight torque down. We're going to be demonstrating the adjustment of the PIIN femur, which is where the femur has gone posterior on the internal side. So we want to bring it back from posterior to anterior. Doctor will stand on the affected side. Patient is supine on the table. Doctor will stabilize the shaft of the tibia close to the joint line. Doctor will use thenar pad contact on the posterior medial aspect of the femur. The line of correction, the thrust is going to be P to A, or posterior to anterior with medial to lateral with a little bit of torque at the end. So we're going to demonstrate it now. So bring it up and set. This is the alternate move for the PIIN femur. The patient is prone on the table or pelvic bench. Doctor is going to stand opposite the affected knee. So the femur has rotated posterior on the internal side. We want to set it from posterior to anterior, getting rid of the rotation, correcting that rotational component. And the way we're going to correct this is we're going to contact the posterior medial border of the femur with our thenar pad, this pad right here, close to the bottom. So thenar pad contact on the posterior medial border of the femur. Whole hand is going to rest on the femur, wrapping the fingers around for stability. Now, to get the joint to tension, we're going to take the tibia and flex it towards the buttock in order to get tension. And right at the point of tension, the thrust is going to be P to A, slightly medial to lateral. Okay? And let's demonstrate. Take the joint to tension, heel to buttock, and it's a set there. We're going to be demonstrating the adjustment of the PEX tibia, which means that the tibia has misaligned posterior on the external side or the lateral side. The nomenclature is PEX, posterior on the external side. So prior to correction of a PEX tibia, we need to check for any capsular bulging on the lateral side. If there's any capsular bulging, we need to reduce that bulging or the adjustment won't hold. Once the bulging of the capsule has been reduced, doctor will stand to the affected side. Doctor will grab the tibia slightly and traction a little bit. Doctor will place his chiro index and chiro index right on the lateral aspect of the tibia, encompassing a little bit of that capsule. With a little bit of traction, doctor is going to flex the knee, maintaining traction, and I'm slightly pushing P to A on that lateral joint. Doctor will bend down and place patient's ankle on the doctor's shoulder. Now, we said it's gone posterior on the external side, so we want to get rid of that rotational component. Doctor will superimpose fingers, get rid of the rotation, bring the elbows in close, and it's going to be a lat pull using more of the outer hand. We want to correct it with the outer hand. So going to traction, take the tension out, and set. Next, we're going to be demonstrating the adjustment for the tibia EX side slip, or an EX tibia, which means there's no posterior component. It's just open on the lateral side, and the whole tibia has shifted laterally. So we want to bring it back from lateral to medial. The correction of the EX tibia, doctor will stand opposite the affected side. Doctor will, with the stabilization hand, will grab the ankle, raise the ankle, and reach underneath the tibia. You're going to contact the lateral tibia close to the joint line with your second, third, fourth fingers. It's going to be a traction down, and the line of correction is going to be lateral to medial. It's going to be a straight pull. If the patient is smaller, doctor has big hands and wants to use the piezoform, doctor can also similarly use the piezoform, traction at the ankle, and it's a straight pull. There's another way that makes it a little bit easier. Those of you that have the Gonstead condyle blocks, you want to raise the whole leg up, and you're going to place the condyle block with the rounded side pointing down, and you're going to place that on the femur. And what that does, it gives you a little bit better contact and positioning of the tibia for correction. As you can see, the tibia is now elevated. It's going to be a lot easier to get to. So we're going to wrap our fingers around. We're on the lateral aspect of the tibia. Traction the tibia down. The line of correction is going to be a pull move. It's going to be lateral to medial, straight pull. We're going to be demonstrating the adjustment of the posterior proximal fibula, which means that the proximal fibula has gone posterior. We want to set it P to A. The preferred move is going to be in the prone position. Patient is prone, face down on the table. Doctor is going to stand on the affected side. Doctor is going to contact the posterior aspect of the fibula with second and third index. The main force is going to come through the chiro index or the middle finger. So once we get our contact point, we're going to traction slightly at the ankle. We're going to bring the ankle up to 90 degrees. I'm on the fibula, proximal fibular head. Now, you can either superimpose your stabilization hand, your fingers on top, or you can use your piezoform. The elbows are going to come in, and the thrust is happening with the outside hand, the hand that's contacting the fibula. And it's going to be a straight pull back. We're going to be demonstrating the adjustment of the posterior proximal fibula. This is the alternate move. Patient is supine, face up on the table. We've added some cushion here for support to make it a little bit more comfortable for the patient. Typically, we would set the posterior fibula forward, but in this alternate move, some patients do better with this. Some patients can't handle the other move because of their pain threshold and tolerance. So in this move, we're actually going to be setting the tibia anterior to posterior while we're blocking the fibula, so it's more of a shearing type force. Okay? We're going to bring the tibia up. I'm going to stabilize the tibia right between doctor's thighs. We're going to be contacting the posterior aspect of the fibula with the second, third, fourth, and fifth proximal interphalangeal joints of the doctor's hand. Right there. Doctor is going to be thrusting with the contact hand that's contacting the anterior shaft of the tibia. We're going to do a slight traction, and the set is going to be straight A to P. We're going to be demonstrating the adjustment and correction of Osgood-Schlatter, which is a condition of the knee where there is an avulsion fracture, an avulsion of the anterior tubercle of the knee. And what happens, it does this. It goes forward. So it comes off the tibia and it does this. This is due to a traumatic incident. This represents the anterior tubercle, which the patellar ligament connects from the inferior pole of the patella to the anterior tubercle. If we have an avulsion, which goes anterior, we're going to have disruption of the mechanics of the entire knee joint. It's going to be very painful as well. Prior to adjusting the anterior tubercle for Osgood-Schlatter, you want to reduce as much of the swelling as possible. The way you'll do that is with specific ice massage. You can also use prolytic enzymes if you'd like. So you take specific ice massage. What I like to do is take some Dixie cups, fill it 3/4 with water, and then we can just tear it off and use that for specific ice massaging. After we've done the ice massage, doctor is going to stand on the affected side. Contact on the patient is the anterior tubercle, slightly superior. It's going to be a medi pisiform. Medi pisiform is going to contact the anterior tubercle. And initially, if you want, you can just do a little bit of pumping action just to kind of get the fluid out of the joint or the avulsion, okay? The adjustment is going to be a single hand contact. It's a medi pisiform, and it's going to be a straight set anterior to posterior, slightly S to I, and the set is that. Depending on the patient tolerance, as the swelling comes down, you're going to need to set it a little bit deeper, like that. You may need 3 to 6 adjustments to correct it. After each adjustment, you want to cross tape in order to stabilize. You can use a pressure pad as well for support. And usually within about 3 to 6 adjustments, it's set in place. Then it's going to take about 6 to 8 weeks to heal up before, we get back on the field. We're going to be demonstrating the relocation of a dislocated patella. Typically, the patient is going to present into your office non-weight bearing on the affected dislocated patella. So we're going to have the patient supine on the table, high-low or pelvic bench. We're going to be standing on the affected side. Typically, when we're relocating a dislocated joint, we have to dislocate it more before the body will re-accept that joint. Okay, and the way we're going to do this, we're going to bring the patient's leg up to 90 degrees. Typically, the patient will be able to take this. How far we're going to be able to bring the knee up is going to be dependent on the severity of the dislocation. This doctor is standing on the affected side. Doctor's contact hand. The base or hypothenar is contacting the lateral aspect of the patella. Doctor is going to then grasp the medial aspect of the patella with second, third, fourth. If it's a bigger patient, even the 5th digit, okay? And the stabilization hand can be at the heel, but as we said earlier, we don't like to cross too many joints, so we're going to go proximal to the ankle. We're going to grasp the medial aspect of the patella. We're going to pull it over as far lateral to the patient's tolerance as possible. Now remember, it's already going to be lateral, but we want to pull it out a little bit more. We're going to flex the patient's hip and knee. And now we're going to start to externally rotate the hip while pulling medial to lateral on the patella. As we're extending the leg, We're going to feel it, want it to go back in place. It's going to start to go right about there and maintain that traction all the way. So patella relocated and sucked right back in. As you notice, I still have pressure on the patella. There may be a little bit of ballottement, which is just swelling under the patella. You can do a little bit of pumping action. And the final move is going to be the set, which is going to be straight, anterior to posterior, slightly superior to inferior, like that. It's a set and hold. And then we want to do cross taping in order to hold the adjustment. We can usually relocate this in one adjustment. It may take up to 3 to 4 adjustments. We're going to be demonstrating the reduction of the lateral bulging of the knee. And what we're specifically referring to is there's the lateral medial meniscus, there's a lateral medial capsule. When we have misalignment of the tibia, we can get a possible bulging of the meniscus along with the capsule. So prior to any adjustment of the tibia, we need to correct that bulge. If you do not correct that bulge, you will not get a stay put on that adjustment. Nothing will ever get fixed. It'll always misalign it again. Okay, so we're going to use a little bit of body butter. You can use lotion or oil, whatever you have in your office. This is for patient comfort. There are some who have a very low pain threshold, and some offices will use some sort of local anesthetic spray in order to make it more comfortable for the patient. So I just added a little bit of body butter there. And what we're going to do is I'm going to have, if you have an assistant, we'll show it 2 ways. This is a larger patient. We're going to demonstrate with an assistant and without the assistant. So first, with the assistant, you're going to have your assistant traction just proximal to the ankle. It's going to be a traction pull and slightly up. Doctor is going to stand on the affected side using the outside hand, going to use the thumb. It's going to be a scooping, arcing type motion. It's going to be lateral to medial, I to S, and P to A. Now, depending on the size of the patient and the strength of the doctor, can use superimpose the inside hand to get a more stay put value. Need the assistant to traction a little bit more, please. So while the assistant is tractioning, doctor is scooping the swelling back into the joint. Once you'll feel that bulge kind of suck back in. Once you feel that suck back in, assistant is still going to maintain the traction, and at that point, doctor is going to place his contact hand, chiro index and index finger, while the assistant maintains traction. Now, if we're setting the PEX tibia, assistant is going to bring the ankle up to 90 degrees while maintaining traction. So let's bring it all the way up. Good. Still maintaining traction. I got it from here. Thank you. Still maintaining your contact and going straight into the PEX setup. We're going to be demonstrating the lateral bulge reduction of the knee without an assistant. Now, doctor will stand on the affected side. Patient is in the prone position on the table. Doctor is going to grab the patient's leg. Doctor is going to place the patient's ankle between the doctor's thighs. Doctor is going to use doctor's thighs in order to traction and open up the joint. Doctor is going to use his outside hand, thumb contact, on the posterior lateral aspect of the lateral capsule and lateral meniscus. Going to use the outside thumb contact while tractioning with the doctor's thighs. It's a scooping type motion. It's going from lateral to medial, I to S, and slightly P to A. You can superimpose your inside thumb to get a little bit more depth. So traction, scoop, traction, scoop, traction, scoop, traction, scoop, traction, scoop. Once you feel that the bulge, you'll feel the bulge suck in. Once you feel that, maintain the tension at the contact point, maintain the traction With traction, you want to bend the knee to 90 degrees. I'm maintaining traction at the ankle, maintaining firm contact point, and then we're getting right into the setup of the PEX tibia. We're going to be demonstrating medial bulge reduction. Basically is when we have a femur misalignment, usually and typically it's an anterior AIN femur, anterior on the internal side. Depending on the severity of the trauma, we could have bulging of the medial meniscus and the medial capsule. So before making any adjustment to the knee, we want to make sure we reduce that bulge. And the way we want to reduce that bulge is patient's going to be seated on a cervical chair, table, or pelvic bench, whatever is available. If we're using a cervical chair, patient will have the back up. Patient will be scooting forward on the chair or table as patient is. Doctor is going to be kneeling down on one knee. Affected leg is going to be up on doctor's thigh. For larger patients, doctor can adduct the thigh in order to get the traction motion. So we want to be reducing this medial bulge here, okay? And the way we're going to do it is we're going to stabilize the tibia and traction the tibia to open up that joint. And it's going to be a scooping motion from lateral to medial, inferior to superior, and it's a scooping motion like this. We're going to use a little bit of lotion, body butter, oil, whatever you have available to make it a little bit more comfortable and easy for the patient. So we're just applying a little bit of this body butter there. Okay. All right, now we're going to be tractioning the tibia. Now for this patient, I'm actually going to be adducting my thigh to get a little bit more traction, slight bend in the knee, and it's a scooping motion. And you obviously want to start out a little bit light, and as it starts to suck back in, if you need to apply more pressure, you can. So it's a scooping motion. It's lateral to medial, slightly I to S. So you traction, open up the joint, scoop in and close. Traction, open up the joint, scoop in and close. Traction, open up the joint, scoop in and close. Now, once you feel that the bulge has been reduced, you can just hold it in position there, and you can go straight to the AIN femur from here, holding and tractioning the tibia, contacting the medial condyle of the femur with the doctor's thenar, a little bit of flexion in the knee. It's going to be the last 5 degrees of extension, and it's going to be a set. It's going to be a lateral to medial, slightly S to I, A to P, and a little bit of torque at the end. Traction, open up the joint, set. Alternate moves for the knee adjustment using the speeder board. We're going to be demonstrating an alternate move for the knee, the AIN, the AEX, and the posterior proximal fibula. We're going to be using a modified speeder board that has a thicker double density cushion. What this allows for is a higher velocity, lower amplitude thrust by the doctor, and it's a lot more comfortable for the patient to receive the adjustment. We're using the exact same Gonstead contacts with the speeder board. So first one we're going to demonstrate is the AIN femur. It's anterior on the internal side, so it's turned this way. We're going to be setting it back. Doctor is going to be standing below the patient. Patient is supine on the table or pelvic bench. Doctor is going to stabilize the patient's leg in between the doctor's thighs. The knee is resting, or the speeder board is resting directly center on the popliteal fossa. There is a little lever mechanism here. You want it up, and on this side there's a tension mechanism to make it tighter or looser here. So doctor contact is going to be thenar on the medial condyle of the femur. Stabilization hand is going to be the anterior shaft of the tibia. Thenar contact on the medial aspect of the femur, right on the condyle, encompassing the joint. And so what we're going to do is we're going to traction by pulling with our thighs and slight pull with the stabilization hand, okay? And we want to just really stabilize that into the speeder board. And it's a set medial to lateral, S to I, and a torque down, just like that. We're going to be demonstrating the alternate move using the speeder board for the AEX femur, which means it's gone anterior on the external side, causing medial deviation of the patella. We've already analyzed it through examination and x-ray analysis, and now we're going to just show the alternate move. So doctor is going to stand on the affected side. Doctor is going to place patient's ankle just proximal to the ankle between doctor's thighs. That's going to allow for traction and some stability for the patient. The contact point is going to be the lateral condyle of the femur, encompassing the lateral joint as well of the knee. Doctor's contact hand position is going to be the thenar pad. Stabilization hand is going to be the anterior shaft of the femur. The line of correction is going to be lateral to medial, slightly S to I, and torque down. Okay? So traction, open up the joint, and set. We're going to be demonstrating the alternate adjustment for the posterior proximal fibula using the speeder board. And patient is going to be supine on the table or pelvic bench. Doctor is going to stand to the affected side. Doctor is going to place patient's leg just proximal to the ankle between doctor's thighs. That's going to allow for stability and traction to open up the joint as needed. So we're setting a proximal posterior fib. And the way we're going to set it here is we're actually going to block the posterior aspect of the fibula with our knuckles, or more specifically the PIPs, or the proximal interphalangeal joints. Okay, so we're going to block the fibula, and it's a fist type knuckle move. No, that doesn't sound right. Start that over. Posterior proximal fibula alternate move. Take two. We're going to be demonstrating the alternate move for the posterior proximal fibula utilizing the speeder board. Doctor is going to stand on the affected side. Patient is supine on the table or pelvic bench. Doctor is going to place the patient's knee between his thighs, just proximal to the ankle for stability and traction as needed. Doctor's contact is going to be the posterior aspect as proximal to the joint as possible, using the doctor's knuckles. Okay, so it's going to be the second, third, fourth, and fifth PIPs, proximal interphalangeal joints, blocking the back of the fibula, and we're actually setting the tibia to the fibula, so it's more of a shear type force. The contact hand, or the thrusting hand, is going to be on the anterior aspect of the tibia. The web of the hand is actually just on the anterior tubercle and encompassing the entire tibial shaft. The adjustment is basically going to be a straight A to P of the tibia, blocking the fibula, the proximal fibula, with the knuckles. Okay, so traction, open up the joint, and it's just set straight down like that.